At age 28, Jennifer's life was to change dramatically. See, she had discovered a lump in her breast. Turned out to be cancer. She underwent surgical resection, followed by radiation therapy to try to eliminate any remaining cells in the surgical field, and then a few cycles of chemotherapy aimed at trying to eliminate cancer cells that might have spread before her surgery, or perhaps even during the surgery. Jennifer thought she was cured. A few years later, in the prime of her life, now engaged and about to be married, she started having some difficulty breathing. Turned out her cancer was back. She had tumors all over her lung. She was again treated with a variety of drugs. All failed. She had a stroke. Now there were tumors in her brain. And she died shortly thereafter, 9 months from the time the relapses, the recurrences had occurred. Now, early breast cancer, which is what Jennifer had, is diagnosed in about 200,000 women in the United States annually. This is not a rare occurrence. And most women who undergo the type of therapies I've told you do well. We, in fact, do sometimes use the word cure for such cases. And yet a significant number do not. In fact, of the 40,000 annual deaths from breast cancer, can any of you hazard a guess as to how many of those women first were diagnosed, first presented with localized disease? I'll give you 3 choices: 25%, 50%, or 75%. So show of hands for those who believe 25% is the answer. Nobody? 50%? A hand or two? 75%? More hands. Well, that's correct. This is a very smart crowd. 75%, 30,000 out of the 40,000 deaths are in women who had recurrence of their localized disease. Now, in other cancers, is this true? Turns out that the proportion of patients with cancer, with different types of cancer, who have early cancer differ quite a bit. Some cancers are diagnosed early, others are diagnosed quite late, quite often. But the number of folks, once they are operated on, those who have operable disease, who recur also varies, and in many cases is even much higher than in the breast cancer cases. So this is a big deal. Despite all of the advances that we've made, all of the invasive procedures, the expense, and the different kinds of therapy for treating localized disease, recurrences do occur, and they take a large toll. So I'd like to share with you today 3 insights that I believe can dramatically change this scenario, and in fact save thousands of lives and potentially billions of dollars in healthcare costs, let alone suffering that's involved. So let's begin by asking about the correlation of events, the timing of events. Often we do this in medicine to understand a disease process. And in this case, let's ask the simple question: when do the recurrences occur? So if we plot the probability of a recurrence as a function of the time after the surgical resection, what would you expect to see? You might expect that following the surgery, this is now time after the surgery, you might expect there would be very few people who would recur. So this is the probability of recurrence at this particular time. There would be very few. The number might go up after a period of time, and then it would probably come down. Remember, these are all patients in whom there was no macroscopic evidence of disease outside of the initial location of the primary tumor. That's why we start low. We may move up a little bit over a period of time, several years, and then down. Turns out that is not what is seen. In breast cancer, what one sees instead is the following curve. You see an early peak of recurrences that's quite high, followed by a fall and then a tail off like so. And this peak occurs at approximately 1 year following surgery. What does that mean? It suggests that there are events that occur at the time of surgery, perhaps the act of taking out the tumor itself. Perhaps it's the wound that is created and the events that follow. Perhaps it's, quote unquote, the stress of surgery. Perhaps it's some of the agents used at the time of surgery for anesthesia. Or perhaps it's something else that we don't know that is fueling this early peak of recurrences. And that is a significant number of patients. That's the area. We're at MIT, so I can talk quantitative things here. This is a large number of patients in terms of the total area under this curve. So let's examine one of these possibilities in a little more detail. And think about the wound healing aspect that occurs following any surgery. Any surgery creates a wound, and nature responds in a fairly stereotyped and well-defined manner. The first step is, in fact, hemostasis. The bloodletting has to stop, and platelets play an important role in this process. They come to the site of the cut, they clump, and they degranulate. Their contents are spewed out. And in these contents are so-called growth factors and cytokines. These are chemicals, these are molecules that in fact incite inflammatory cells to come into the area of the wound, part 2. That's referred to as inflammation. And then the process of sterilizing the wound occurs and repair begins. And as part and parcel of the repair, there is regeneration of tissue that has been wounded. New blood vessels form, connective tissue reforms, and the epithelial cells, the cells that line the skin and other organs, multiply and close the wound. Now that's all good news. But here's the bad news. When this happens in the context of a cancer, for example, following surgery, what effects might occur that are deleterious to any remaining cancer cells? Those factors that I just talked about don't just sit in the location of the surgical wound. They circulate. And if they do circulate, they are doing what? They might, in fact, wake up dormant cells, cells that may not be multiplying, but that may have spread already in the patient, and get them to start multiplying again. Turns out platelets themselves can cloak cancer cells and help them to evade immune and other mechanisms and help them to spread. And voila, over a period of time, one has these early recurrences. We often resort to animal experiments to give us some cues about whether this hypothesis or these sorts of ideas make sense. And here's some data over 50 years ago. In this experiment, the Fisher brothers introduced 50 cancer cells, approximately 50 cancer cells, into the portal vein of a rat. The portal vein drains into the liver. And they then asked the question, what happens 5 months later? And as you can see up here, no tumor growth was seen. But then they did something very interesting. At about 3 months, they decided to repeatedly injure these animals in the following way. They opened up their bellies. This is called a laparotomy. And they did repeated laparotomies every few weeks. And then when they looked at 5 months, there were macroscopic, huge, visible tumors in the liver. So what does this mean? 2 things. Number one, it tells you very directly. And remember, this is an experiment done in the 1950s. There was no particular way of labeling tumor cells. This tells you that tumor cells can survive for long periods of time without multiplying. They can lie, what I told you a few minutes ago, they can lie dormant. And number two, that they can be taken out of their dormant state and start multiplying by repeated wounding. Wounding that occurs quite far away from where those cells existed. Wow. This is a big experiment. Now, you say to yourself, can you intervene in this process? Well, maybe. And maybe you don't need to look that far away. Just look in your medicine cabinet. We have drugs that can intercept the process of wound healing. And those drugs, simplest ones to think about, are the so-called anti-inflammatory drugs. Aspirin, ibuprofen, and all of their relatives. These drugs, in effect, block the inflammatory response. They actually block more completely the wound healing response. In fact, one of the side effects is bleeding. They will change the way the inflammatory response occurs, or at least slow it down. And so the hypothesis is straightforward. What if we gave these drugs prior to the surgery? And the key is they would have to be administered prior to the surgery in order to stop the wound healing response right in its tracks. Well, is there any evidence that this works? So it turned out a few years ago, a young Belgian student was working for his doctoral thesis. And he decided to simply ask the following question. In women who had undergone mastectomies for breast cancer, was there anything that was done in the perioperative period, that is the period just before the surgery, during the surgery, and after the surgery, that influenced outcomes, that influenced the recurrence rate? And he just cataloged what happened. In whom did the tumor come back? Which patients? Who survived the longest, and so on. And here's what he found. In those patients who pre-incisionally, in other words, before the incision, got one dose of a non-steroidal anti-inflammatory drug, a cousin of aspirin, called Ketorolac, given intravenously, the recurrence rate was down by about 70%. Take a careful look at this curve. The green signifies the hazard ratio, the probability of recurrence as a function of time, exactly this curve. In those patients who did not receive Ketorolac, that's the top curve. And those who happened to get the Ketorolac before the surgery, and this was done fairly randomly, these were actually 300 consecutive patients. Some got Ketorolac and others didn't. About half of them got the Ketorolac. Take a look at what that curve looks like. That's the bottom curve. And that bottom curve, in fact, looks like the curve you might have predicted had surgery nothing to do with inciting these recurrences. Quite interesting. All right, it turns out when you do the math, over 10,000 lives annually would be saved in the United States if this were to be true in a prospective study. More about that in a few minutes. This is all retrospective data. And this costs about $10 for every administration. Now, is this applicable to other cancers, you might ask? It turns out the same kind of bimodal curve is seen in lung cancer and in several other cancers. One has to look for it carefully. Believe it or not, this data is actually fairly recent. And in fact, in lung cancer, there is also some data that in those patients who got Ketorolac or one of its cousins, diclofenac, prior to surgery, there is also a reduced recurrence rate. So insight one is that anti-inflammatory drugs administered before surgery may cure more early-stage cancers. So the obvious question is, why are cancer patients slated for surgery not receiving Ketorolac routinely? If you were to go to a hospital today and unfortunately had cancer, and you asked your surgeon for Ketorolac, he or she would probably say 99% of the time, at the major academic medical centers to which we all belong here in Boston, many of us, the answer would be no. Why not? Why has this not become the standard of care? Because what I have told you is a certain kind of evidence. The evidence is retrospective. It simply shows there's a correlation of those who got the Ketorolac diminishing or correlated with the relapse rate, and specifically the early recurrence rate. And this is just a cartoon to illustrate that. It says this little fellow, I wish they didn't turn on that seatbelt sign so much. Every time they do, it gets bumpy. So what is needed, of course, is a prospective study, a randomized study, ideally, in which a certain number of patients are given Ketorolac and a certain group are not, and then to look at outcomes. And that's how, of course, a new standard of care is established. There are other reasons why a surgeon or an anesthesiologist may refuse to give Ketorolac in this setting with the data that I have just cited. There are risks involved, and a proper study, in fact, will evaluate those risks. There is a risk of bleeding. There is a risk of perhaps an inability to heal the wound as rapidly. And so that has to be weighed against a prospective benefit. And without the knowledge of that benefit clearly in hand, in the form of a prospective randomized study, many physicians, most physicians, will refuse to administer this drug preoperatively. It's often used postoperatively, by the way. But the reason it was given preoperatively in these patients was because somebody wanted to simply reduce the morphine usage that is routine postoperatively by giving the drug early on in the game. That's how it all started, serendipity, if you will, at its best. So the conclusion from this is we do need a trial because of the type of data that we currently have. So here's the third insight. We need public funding to get this trial underway. That might well be the fastest way to get the ball off the ground. Now let's spend a minute on this. The way drugs are developed is that, first of all, there has to be some understanding of a disease process, and that usually occurs in the laboratory. The National Institutes of Health, many foundations, in fact, most foundations, fund that sort of work. It takes years. And following that, opportunities arise for drug development, and that's where industry steps in. They look for those opportunities, and they then they develop the drugs, and they move those drugs into human testing to look for their safety and to assess their efficacy. But before pharma does that, they also have to assess, because trials are expensive, they take a long time, they're inefficient, many drugs fail, they have to look for a return on their investment. That's their fiduciary obligation to their shareholders. So if the return on that investment is not adequate, if the market size is not adequate, if they don't have patent protection for the drug, they generally will not be interested. A study of Ketorolac given before surgery is not one that generally will interest pharma for the obvious reasons I've just stated. So what is one to do? These are clearly untapped opportunities. Existing drugs, drugs that are off patent, new uses for these in a variety of diseases. We refer to this often as repurposing of drugs. Somebody has to move this agenda forward, and that somebody has to be the public or somebody who represents the public, such as the government. Otherwise, these promising ideas, promising because there's retrospective human data, promising because there's animal data, may never move to definitive human studies, and therefore will not be available to patients. And so it's for that reason that Vidula and I formed this organization called GlobalCures. That's the goal of this organization, to focus as a nonprofit on these so-called financial orphans, these untapped opportunities. To identify, first of all, what they are in cancer. Secondly, to design the clinical trials, enroll the patients and the physicians and get them excited about this. And then to actually do the trials or help with the trials, but first one has to raise the money to do it. And that's, of course, one of the jobs of GlobalCures as well. So remember Jennifer. She was the inspiration for this organization. She was my wife's good friend. And the big picture is, that what I have told you may apply not just for early stage cancer, but for all cancer treatments for many or all cancer types. Now that is making a big statement. What I'm saying is that countering the wound healing response might improve outcomes in patients with advanced cancer as well. Cancer that has spread, for example. So here's the logic. About 40 years ago, my good friend and colleague, Dr. Harold Dvorak, at Beth Israel Deaconess Medical Center in Harvard Medical School, I just had lunch with him yesterday, advanced the notion that in fact cancer resembles a wound. An untreated cancer resembles a wound. He's a pathologist, and he noticed the similarity between these two. Fundamentally, here's what he was saying. When a cancer, by definition, starts growing, cells are multiplying, they many times outstrip their blood supply. They lack certain nutrients. They don't get enough oxygen. The they is portions of the tumor, not the entire tumor. And those portions of the tumor die. Hello? Cell death, that's injury. The wound healing response kicks in. And this is what Dr. Dvorak observed. He observed those platelets clumping in there and all the other things that I have described to you in a natural setting of a rapidly growing cancer. And so the cells that are surviving, that do have an adequate blood supply, are further fueled by all of the things that I told you just a few minutes ago. But there's more. Every treatment for cancer makes the situation even worse. I've told you about surgery already. What about chemotherapy? What about targeted therapies? What about radiation therapy? Its goal is to kill and kill more cancer cells. And those that it kills, that's great. Those that are killed, it's fine. But there are many cells that are not killed, and for those cells, they get a second life. In fact, it is that subset of cells that tend to become resistant to these therapies for reasons I don't have all the time to get into. And there is data that if you pre-treat or treat concurrently with drugs such as ibuprofen, at the time of these interventions, one can markedly change the outcomes. This is data in animal models. And so a short course of intervention of drugs like these that are amazingly inexpensive and other drugs that work on the wound healing process could have dramatic repercussions in terms of improving cancer outcomes. That's the really big idea. So you say, Vikas, could it be so simple? Am I just a little bit crazy? So let me end by telling you the story of Ignaz Semmelweis. Here's the gentleman, lived in the 19th century, and as a newly minted obstetrician, he was put in charge of 2 maternity wards. And he noticed something rather odd. Turned out in those days, many women died after childbirth. They died of a disease called puerperal fever. Turns out it's an infection due to certain bacteria. We now know. Not known, of course, at that time. But here's what really bothered Semmelweis. The rates of infection were very different in his 2 clinics. The first clinic had much higher rate, as you can see over time, than the second clinic. It was always higher, by about 3-fold, 4-fold. And you can see the numbers are quite high. And women knew about this. They vied to get into the second clinic. They did all kinds of things to make sure their deliveries would occur, if you will. Not easy to do. In the second clinic. And Semmelweis asked the simple question, what's the difference? Well, it turned out the first clinic was staffed by medical students and physicians. The second clinic, with the lower death rate, the deliveries were done by midwives. And so you say, well, I mean, how does this work? Does this make any sense? The breakthrough came when one of Semmelweis's closest friends was accidentally cut by a medical student's scalpel during an autopsy of a woman who had died of puerperal fever. His best friend died. And he died of puerperal fever. That was the epiphany. Said Semmelweis, it must be that the hands of these folks, the medical students, the physicians, are dirty. They are carrying cadaverous particles, whatever that means. And they're not washing their hands adequately before they deliver the babies. And hence they're transmitting the disease. And he even suggested the use of a chlorinated hand wash solution, because this solution decreased bad smell in the autopsy room. That was his reasoning. And he was able to convince a few folks to do this. And sure enough, as you can see in this slide, the rates of death rate plummeted once chlorine hand washing was instituted in mid-1847. Very dramatic indeed. And yet, this inexpensive, safe, and easy procedure was not adopted. In fact, there's a long story. Semmelweis went crazy and died under very sad circumstances. And so it's worth asking, why not? And it's worth comparing our two stories. The disease framework was not what people were receptive to. Semmelweis was talking about some transmission of a disease. Disease was felt in those days to be due to some imbalance of bad humors. This made no sense. Fast forward, I am telling you that the wound healing hypothesis is not yet accepted, even though there is plenty of data. It's been largely ignored by the oncology community. The second reason was that everybody, at least in those days, thought that patients were unique. Their humors were imbalanced in different ways. How could one therapy, especially one that was so simple, work so dramatically in so many patients? It just couldn't be true. In our zeal, fast forward, to embrace personalized medicine and figure out all the genetic mutations in a tumor cell, we have ignored, until very recently, as Dr. Lowe told you, the immunotherapy work, we have ignored the cells outside of the tumor. And in fact, in the entire talk I have given you, I have focused exactly on the cells other than the tumor cells, as inciting those tumor cells to do bad things. So the world is gradually changing, but it's not quite there yet. And thirdly, Semmelweis was pointing the finger at his fellow obstetricians and telling them that they had unclean hands. Now that just did not go over very well. And I'm saying to the surgeons and the anesthesiologists, you're doing a great job because you're curing a lot of women on whom you're operating. But you are inciting certain cancers to recur sooner than they otherwise would have. And you can't have your cake and eat it too, but you need to do something about that. Where are we in all of this? We could either repeat history or we can change it. So the ask is simple. A trial of preoperative Ketorolac has begun in Belgium, funded by an organization called the Anti-Cancer Fund, which is a sister organization to ours. We have a very close relationship with them. We are proposing here that we begin a trial in lung cancer in the United States. We've lined up a protocol, we've lined up physicians, and it will cost approximately $4 million. That's what's waiting to get this off the ground. And I would like you folks to join in this effort, to test whether this inexpensive and safe and easy remedy intervention can in fact make a difference in cancer survival. The time is now. We are the potential beneficiaries. And remember, what started off as a simple hand-washing procedure before delivering babies has transformed all of medicine and surgery. This Ketorolac study could be paradigm shifting for all the reasons I have given to you and transform the care of all cancer patients, those with early disease and potentially even those with late-stage disease worldwide. Thank you.